Again, I am Ron Strochlic with the University of California Division of Agriculture and Natural Resources, and I want to welcome you all to this last session on community interventions to improve farm worker health and well-being. Our first panelist today is Irisela Contreras, and she is with the Mixteco Indigena Community Organizing Project in Ventura, California. Irisela graduated from Cal State University Channel Islands with a major in sociology and a double minor in Chicano-Chicana studies and Spanish. She grew up in Mexico and migrated to the United States at the age of 14 years old. She is a proud daughter of former farm workers who came from Mexico searching for a better future opportunity for their family. As a young researcher, she is interested in the life experiences of Latino immigrants and indigenous populations with a focus on reducing health disparities and social determinants that increase individuals and families' prevalence to mental health disorders. Ms. Contreras will be presenting on living love, reducing mental health disparities for migrant indigenous communities. And just before the presentation begins, just a couple of housekeeping items that I neglected to mention. Each presenter will have 12 minutes to present. I'll give you a 2-minute warning or heads up. And also, if everyone could please type your questions into the Q&A box and not into the chat, that will be really helpful. And Crystal, please chime in if people should be doing it directly for the panelists, or if it's just the general Q&A. I wasn't quite clear on that part of it.
Yeah, if there's just any questions, go ahead and just type them into Q&A, just if we have any questions for any of our panelists at the end. And if we're unable to answer them or run low on time, then we can have the panelists type into the Q&A and answer the question if we run out of time.
Cool, thank you. And just one other thing, I just got a note from the translator that I'm speaking too fast. I apologize. So if the presenters could also please speak slowly, that would be great. Okay, thanks very much, everyone. And go ahead, Irisela.
Thank you. Thank you, everyone. And thank you for the opportunity. My name is Irisela Contreras, and I'm here representing the Mixteco Indigena Community Organizing Project, and also my team members, Dulce Vargas, Teresa Santos, and Leticia Galicia, who are also here listening to the presentation. So our presentation is titled Living with Love, Reducing Mental Health Disparities for Migrant Indigenous Communities. Just a brief disclaimer, today's presentation doesn't apply to all Indigenous cultures and or beliefs. Our presentation focuses on Mixtec Indigenous communities and other communities of Mexican origin that doesn't necessarily identify as Indigenous and that participated in our project. So we are a nonprofit organization serving migrant indigenous communities throughout California's Central Coast. Our mission is to support, organize, and empower the indigenous migrant communities. We have over 20 programs focused on education, interpretation services, health access, culture promotion, labor rights, and immigration assistance for our communities. We are also the home to Radio Indigena 94.1 FM, a community radio station broadcasting in indigenous languages. So today we're going to be presenting only on one of these of our projects. So our community, Ventura County, is home to 20,000 indigenous migrant communities from the Mexican states of Oaxaca, Guerrero, and Michoacan. A large proportion of our community is undocumented, and a great proportion only speaks their indigenous languages. The majority are agricultural workers working in the strawberry, blueberry, cilantro, and other fields. As you know, farm workers earn very low wages, and also this type of environment places our communities at higher risk of labor abuse, exploitation, harassment that is often rooted in negative stereotypes against our community. So understanding the mental health needs of our migrant indigenous communities. So first of all, the term mental health is unknown for Mixtec indigenous communities, and as well as related symptoms and mental health problems are identified using different terminology within the community. Mental health is commonly identified with physical symptoms that may be affecting the social, physical, and emotional well-being of the person. For example, when looking at depression, depression is associated with a stage of sadness that the person might be experiencing as a result of a susto, a shock, a mal de ojo, which is negative energy or any other external event, but not associated with mental health Also, when our community, as our community migrate to the United States, they confront themselves with the acculturation process and also with new perceptions of mental health that is unfamiliar to them. Other risk factors that are also associated with mental health that affects our community is domestic violence, the migratory dual, the grief of leaving behind their home, their culture, and their families, restricted mobility, not being able to go back to their communities, and children left behind. The living conditions are sometimes our communities are living in homes with multiple families, alcohol and drug abuse. So other, cultural and systemic barriers that affects the ability of our community to access mental health services is, first of all, the cultural mistrust and stigmatizing beliefs of mental health. Our community fears that the services might be associated with the government, being labeled as crazy, or how they will be seen in the community, the lack of health insurance and high cost of services, the lack of culturally and linguistically appropriate services that really understands the life experiences of migrant indigenous communities, their beliefs and cultures, inconvenient service hours for a farm worker community, and other barriers as well. So today we're going to be presenting about our Living with Love project, which is a direct prevention and early intervention mental health and domestic violence project for migrant indigenous women. So this project is funded by the California Reducing Disparities Project, which is a program of the California Department of Public Health, Office of Health Equity. So this is a culturally responsive mental health initiative that funds 35 culturally responsive, innovative implementation pilot projects across the state of California within 5 different population groups. And the goal of this initiative is to demonstrate the effectiveness of community-defined, evidence-based practices to reduce mental health disparities. So the Living with Love project was written by MICOP's Mexican Indigenous promotora, Dulce Vargas, and a consultant educator, Barbara Marquez. The project is being implemented by 2 migrant Indigenous promotoras as well. And this is an 8-week bilingual Spanish and Mystic program delivered throughout different community settings where our community reside. So we partnered also with the UCLA Kaiser Permanente Center for Health Equity to conduct the evaluation of the project. So our current goals are to increase mental health knowledge and reduce the stigma, increase knowledge of domestic violence, reduce social, cultural, and linguistic isolation, improve the capacity to manage daily stressors, and improve the knowledge and connection to mental health services. So this is just a brief overview of the structure of our program. So the project is delivered by migrant indigenous promotoras, who are trusted community members who share the community's life experiences, the knowledge, and the language. We have a community advisory board who has been providing guidance throughout the project development and evaluation to ensure that we are meeting the needs of the community. We also engage in grassroots outreach efforts, conducting, going door to door and personally establishing trust and connection with our community. We are visiting also the agricultural field, the swamit, laundromats to invite our community to the program. We conduct also case management. This is a very important element of the program, where the project serves as the bridge between families and resources. We provide support and guidance to families in domestic violence and mental health cases. And finally, we have the peer support groups. The project is delivered in safe and welcoming group spaces where the people find other people with similar life experiences that can support each other. We provide childcare and snacks for our families, because we know that this is an essential part that if we didn't have this part, they wouldn't be able to participate in the program. A lot of our participants come straight from work to the program, so it is important to have these elements as part of the program. So these are some of the implementation challenges that we have confronted. First of all, the role of family and work responsibilities. The lack of interest in this type of programs due to the stigma, or because our community is unfamiliar with this type of programs. Balancing the project demands with limited staff and funding. Navigating the mental health system, especially the lack of culturally and linguistically appropriate services to serve a migrant indigenous community. And the evaluation, conducting the evaluation in an oral language and the limited staff has been also a barrier. So these are just a brief overview of the response of the project and specific to during the pandemic. So when the pandemic hit, we had to cancel all of our in-person activities. So we started to see how our community was struggling with the loss of employment, housing and food access problems, increase in family stress, domestic violence, mental health problems. So the project started reconnecting with the community through checking costs and providing food distribution, going home to home and delivering these food pantries, connecting them to resources and providing case management during that time. So observing the needs that were increasingly that were increasing in terms of the mental health and domestic violence, the project transitioned to virtual one-on-one peer support sessions to continue providing a service to the community during this time. The response of the community has been very positive. We are seeing very rich and thorough conversations. I think the community really liked the safe space provided and the personalized attention that this approach gives them. So this is just a brief overview of what we have done during COVID. So today, we're just gonna share with you, some pre-post changes from preliminary data that we have collected throughout the years. So we have currently 31 in-person groups, over 70 virtual one-on-one peer support sessions. We have over 200 participants who completed a pre-evaluation for local evaluation. And we have a 78% retention rate within the project. And we have also been conducting focus groups as part of the informing the project development. So these are just some of the constructs that we have been looking at in the evaluation, such as social support, family relationships, self-esteem, and others. And this is just a brief overview of participants' characteristics. So participants' age range is from 17 to 75 years old. We have people who have been living here in the United States between 1 through 50 years. And we also have 12% of participants who spend part of the year in another city. And this is important because we know that a lot of our communities migrate to other counties to follow the crops. So this is an important percent there.
More minutes, please, Irisela.
Thank you. So this is just some pre-post changes from t-tests that we conducted. So as you can see, we have seen increases in nearly every metric targeted by the program. We have seen changes in the social support, family relationships, domestic violence, knowledge on mental health. So the only ones that we haven't seen that much growth is self-esteem and stigma, but we are starting to see that the numbers are moving the way that we want them to be. And this is just some overview of the focus groups that we have conducted. Some topics that have emerged from this analysis, which is the sense of belonging and reduced isolation, the increased knowledge on mental health and domestic violence, the personal growth and resiliency that participants are getting through the program. And this is just some of the most helpful aspects of the program for the community, which is the effective communication skills, the atención plena, mindfulness, deep breathing, and learning not to overthink, and others. And just wanted to end this presentation with a very, a quote that really connects with me. It says, cuando yo empecé a venir, me gustó, me empecé a sentir muy bien con lo que ustedes hablaban, se sentía muy bien mi corazón. And I just want to thank my team members and especially our community advisory board for all the support that they have given us throughout the implementation of this project.
Thank you so much, Irisela, for that wonderful presentation. Our next presenter is Kalia Fleming. MPH, MCHES. And Ms. Fleming is with the H. Lee Moffitt Cancer Center and Research Institute in Tampa, Florida. Thanks so much. Thanks, Dr. Cofie. Please go ahead. I don't know if you're on mute. Dr. Cofie, you might be on mute. We're not hearing you.
How about now?
Yes.
Great. Thank you for the introduction.
Yep.
All right. I will begin by providing a brief background on farm workers in North Carolina. The state relies on labor from farm workers to cultivate its crops, notably work-intensive crops like tobacco and Christmas trees. Farm workers in North Carolina are of mostly young Latinx males who primarily speak Spanish. Recent estimates suggest that over 78,000 farm workers worked in the state in the year of 2018, and between 14 and 17,000 of them actually had H-2A visas. In terms of community health workers, we know that community health workers provide health education and enabling services to farm workers in order to facilitate their access to healthcare. Most community health workers in the state are mostly female, identify as Latinx, and primarily speak Spanish. They tend to work in organizations such as nonprofit organizations, migrant community health centers, and also local health departments. Community health workers are essential in providing services to farm workers in that they provide relevant services such as health evaluations, referrals, transportations, and interpretations. Previous work on understanding the importance of community health workers to providing social services and health enabling services to farm workers is very limited. And more importantly, the role of community workers in providing health education to farm workers is little understood. So as part of a larger project to enhance the capacity of community health workers to provide health information to farm workers in North Carolina, we sought to both examine the experiences of community health workers in acquiring and disseminating health information, and to also conduct a technology needs assessment to identify opportunities to reduce farm worker health disparities. We conducted 3 focus group discussions with community health workers in North Carolina in the spring of last year. 1 focus group was held in the western part of the state and 2 in the eastern part of the state. We used semi-structured interview approach to conduct the discussions in both English and Spanish. The interviews were audio recorded and transcribed. Using in vivo version 10, we managed their data transcripts and also analyzed the data. We designed a code book which was applied to the and refined along the ways. So essentially the code outputs, code summaries were created from the code outputs, and also along with the memos that were maintained throughout the data collection and data management, we were able to develop matrices to compare the experiences of farm workers in the process of preparing and also disseminating health education to farm workers. From our analysis, we identified 3 key themes in understanding the experiences of community health workers in delivering health education to farm workers. These included their approach to preparing for health education, 3 important health delivery or health education methods they utilize in effectively providing health information to farm workers, and also the role of technology in providing health education to farm workers. In terms of their approach to preparations, community health workers describe both short and long-term preparations that they engaged in preparing for their health education outreach. Short-term preparations basically refer to activities that community health workers engaged in a few hours to immediately before their health outreach. One study participant provided the following explanation, and I quote, "We also carry a lockbox, which carries our materials, health education materials, and also the patient's information. So we prepare the day before, but then hours before we go, and we are at the clinic." In terms of long-term preparations, this refers to activities that community health workers engage in order to maintain and improve their capacity to provide health information to farm workers. One study participant explained, and I quote, "Yes, that happens during the off-season, which is when we don't do so much outreach. That's the time we take the advantage to do trainings, webinars. We invite people that we know have the knowledge and the capacity to come and train as well." The second important theme refers to the various health education methods that community health workers engaged in providing health information to farm workers. And these included open-ended questions, participatory and interactive methods, and nonverbal aids. In terms of open-ended questions, some community health workers explained that they utilize these questions to help farm workers discuss their health needs, and also to assess the health information that farm workers are able to retain or have been able to retain in previous educations. And this was also a way for them to empower seasonal farm workers to act as peer leaders. To provide an example, one study participant provided the following quote, "Okay, when I do outreach, we have to do health assessments. I use it more like a conversational tool when I give that health education. It's based on a question that I'm asking. So if the person is concerned about diabetes, I stop my questionnaire and I just go ahead and start explaining to them. Sometimes this takes a little bit of time, but in the end, it's worth it." The second health education methodology, which is interactive and participatory methods, basically refers to specific activities that requires the involvement of farm workers when delivering health education. Outreach workers explained that these activities were more engaging than disseminating health pamphlets or even showing videos. And also the activities were very useful in situations when farm workers have limited time to interact with the community health workers. So one study participant provided the following quote, "There have also been role-playing or skits at the camps, like theater plays, but small. So we do the role-playing. If we're talking about pesticides, how to eat healthy, what happens if you exercise, then we'll make a theater play and they act." So for them, it's super fun and they like it a lot. Community health workers also explained that they utilize nonverbal aids such as toolkits and models as a means of allowing farm workers to visualize and also interact with the health education materials. And this subsequently enables the farm workers to actively engage with the community health workers. One study participant provided the following quote, "So for instance, we have one about hand washing, but we have our kit so they can learn how to wash their hands and how to do it right." So that's also something to engage their attention in a different way. The third and final theme refers to the use of technology in their health education process. Community health workers describe their current use of technology and also important challenges that they incur while in the field. They also describe some other technological resources that they perceive would be very useful to them. But throughout these conversations, one thing we observed was that community health workers kept referring to the importance of internet access and how that was essential to engage in farm workers in their health education outreach. One study participant provided the following quotes. "We use hotspots as well, and I've had that happen where sometimes Wi-Fi cards don't work in that location. So we have to kind of go back to the paper charting and the paper pamphlets rather than showing anything on the tablets and stuff. But I feel like if there was a way to like download the information and that you can have access to it whenever you don't have online services, then that would work. So for the sake of time, I want to quickly end here by pointing out that the findings from our focus group discussions reveal opportunities to improve farm worker health education through professional development for community health workers, identification of preferred methods of health education delivery to farm workers, and also provision of technology to farm workers serving organizations. These are key points that are worth delving into later on. And so I'm happy to take any questions in the question and answer portion of this panel. Thank you.
Thank you so much, Dr. Cofie, and thank you so much to all of our presenters. I am not seeing